Now let's talk about the development of the cardiovascular system. Before we proceed, let me just remind you of uh, the oval disc of the embryo. This is the bilaminar disc, which uh, which is formed by the end of the second week of development. And if we take a cut here through the amniotic cavity, we would see this view, an oval disc. This is the future cranial end of the embryo. The oropharyngeal membrane indicates this, and of course the more prominent and obvious landmark is the primitive streak, as it is located caudally. Now there are general questions we need to just go through them about why the embryo needs the vascular system. Simply because the embryo is no longer able to satisfy its nutritional requirements by diffusion alone. Because in the first and the second week the embryo is so small, and diffusion can be efficient. After that, for the third week, with all its major events, of course, the blood supply needs to be systematic. The cardiovascular system needs to be there. It appears in the middle of the third week, as I just mentioned, as the first major system to function in the embryo. To function, not to appear, but to function. The first system at this time during the third week is during the process of neurulation. It's the nervous system. But here you go, the cardiovascular system is beginning to function. As we proceed, we will talk about this. Where it appears, the cardiac progenitor cells lie in the epiblast. So the origin of the cardioprogenitor cells is the epiblast. No wonder. We are talking about the middle of the third week. So what we have is the epiblast, hypoblast, and we are just about to create or form the next or third layer, which is the mesoderm. So certainly the origin of the cardiac progenitor cells is the epiblast. And as the cardiovascular system develops, the contribution from the neural crest is to be witnessed later on, especially in the septation of the ventricles of the heart. We will talk about the neural crest role and involvement for sure. Now, in this diagram, I would certainly show you again the orientation. This is the primitive streak, this is caudal, this is cranial end, and of course the cardiac progenitor cells migrate from the epiblast through the primitive streak in a cranial direction on each side of course the notochord, around the precaudal plate, as you can see in this diagram. So they migrate from the primitive streak towards the cranial end, from caudal, as this indicates here, from caudal to a cranial side. Now Where do the cardiac progenitor cells migrate? They migrate into the splanchnic layer of the lateral plate mesoderm. Let me just remind you that we have three types of mesoderm: paraaxial mesoderm or medial mesoderm, intermediate mesoderm, and the lateral mesoderm. Now, the lateral mesoderm divides into two parts, and it forms the interembryonic coelom. So if you look here, this is the parietal part of the lateral mesoderm with the body wall, and of course the visceral layer which covers the endoderm that would form the gut later on, and between them the interembryonic cavity, the coelom that would be the thoracic and abdominopelvic cavity. Then the diaphragm would separate these cavities into thoracic and abdominopelvic below. Now, that was an orientation. The cardiac progenitor cells migrate from the epiplast through the primitive streak towards the caudal end, and they settle in the splanchnic layer here of the lateral plate mesoderm. So the origin is the epiplast. The way they migrate is the primitive streak. The direction from caudal to cranial, and the place they settle in is the splanchnic layer of the lateral plate mesoderm. Now, the cells from both sides meet, this migration of the embryo on both sides, and they form primary heart field. These cells will form the atria, left ventricle part of the right ventricle. You shouldn't memorize this, as we will talk about the details later on. Then another wave of migration would take place, and we call it the secondary heart field. Now all these cells, they are to form the cardiac tube eventually. Therefore, these cells are paired endothelial strands. Here they form paired endothelial strands or cords, angioblastic cords, the same cells that they were migrating, and they are forming two angioblastic cords, appear in the cardiogenic mesoderm during the third week of development. So the same story that we talked about here, it is to be just discussed in this slide. So the cells, they form as they migrate, and they settle in the splanchnic layer of the lateral mesoderm. They form two strands of angioblastic cords. These two cords, as you can see, are on both sides. If we look at this picture here, you would see that we have really two cords on each side of the embryo, and these cords are they don't have cavities yet. They are just cords. They are not tubes. They are just cords. These cords canalize to form two heart tubes. So there is a process of canalization within each cord. By the end of this process, the cords would become tubes that soon fuse as the embryo folds laterally. So we are talking here about two processes: canalization, and at the same time, if you remember, the amniotic cavity would push the sides of the embryo So what we call in a process we call the lateral rotation, folding of the embryo. So this tube that has been canalized and the other one which also has been canalized, they would meet in the middle as you can see here, and they form one tube. So we have epiplastic cells migrating through the primitive streak from caudal to cranial, and they settle in this planktonic layer of the lateral mesoderm, and then they form angioblastic cords. These cords, they canalize, and due to the lateral folding of the embryo, the two already cardiac heart tubes, they meet and they form a single heart tube, as you can see. Now this is the ultimate result, one cardiac tube. Now also it has to be mentioned here that these cells that we talked about here in this picture here, some of them of course they would form the heart, but also other cells, they would, as it states in this slide, they would form the dorsal aorta. So we are talking about not only the heart here, but also the major blood vessels such as the dorsal aorta. Now let's talk about the formation of the cardiac loop. What we have by now, we have the heart is essentially a straight tube with a caudal venous end and a cranial arterial end. So if we to look at the heart tube that has been formed due to lateral folding, it would have a cranial end that is arterial and a venous end that is of course caudal end, I mean, that is venous end. So we have a tube with two ends, a cranial end that is an arterial end, and the caudal end that is venous end. It lies within the pericardial cavity by now. It is attached posteriorly only by dorsal mesocardium. We may talk about this later on. And the embryo, for your surprise, now is about 2.2 millimeter long, is approximately 23 days old, begins to beat. So we are talking about the 4th week of development, and the heart here is beating. The heart is one tube, and of course differential growth defines 5 segments of the heart tube. And now we can recognize and we divide this heart tube into 5 regions, from below above. And why we name them from below above? This is the way the blood coming from the placenta through the umbilical vein reaching this area, and then it goes through the heart, and that's why we would say sinus venosus, then primitive atrium, primitive ventricle, bulbus cordis, and the bulbus cordis here, and truncus arteriosus there. 5 segments, 5 parts of the heart. You need to know them. You need to know how we name them from caudal to cranial as we go up. So what we have until now, the cardiac tube, the heart tube, has differentiated into 5 segments. You just need to know the names of these segments or parts, of course, sinus venosus, then atria, then ventricle, then bulbus cordis. This is new, something new, and truncus arteriosus. Now, this is the arterial end that we talked about, and it is important for you to understand that this part is fixed by the pharyngeal arches that we talked about in the development of the head and neck, so they won't move. However, the venous end is also fixed by the septum transversum, and this septum, we may talk about it later on, but the bottom line here in this slide, at this time of development, the cardiac tube has two ends, arterial end, cranially, caudally, venous end, and both of them until now they are fixed. So from now on, you need to understand that each part of the tube would eventually gives us its derivatives, and that's why you need to memorize this part. The truncus arteriosus would divide into ascending aorta and pulmonary trunk. Bulbus cordis, this is the aortic vestibule. We talked about the smooth area in the, of course, left ventricle. Conus arteriosus of the right ventricle. This is also the smooth area of the right ventricle, the infundibulum here. And the ventricle that differentiate into trabecular wall of the left and right ventricles. If you remember that I've highlighted these facts when we talked about the anatomy of the right ventricle. We said the right ventricle has two parts, rough area in which is inflow, and the outflow is a smooth area. We talked about this. Now embryology just making this obvious that they were coming from different sources. Those were the, of course, the left ventricle also has a rough area and smooth area, and finally the atrium, auricles, musculopectinate, muscle wall of the left and right atria, smooth wall of left atrium from pulmonary veins. Now this here I should say that the atrium give us the rough area in the right atrium and the left atrium. The smooth areas are for example from the coronary sinus, from the sinus venosus for the right atrium, and the smooth area for the left atrium is coming from the pulmonary veins. So everything we have studied in the anatomy, gross anatomy of the heart, as you can see, we could have easily, we can easily find its origin from this cardiac tube, except the smooth area of the left atrium, which is a contribution from the pulmonary veins. So let me summarize to you again. You need to know that we have a cardiac tube. It has parts. You need to know the names: sinus venosus, primitive atrium, primitive ventricle, bulbus cordis, and truncus arteriosus. Then you need absolutely to know that it has arterial end cranially and caudal end venous, and both of them until now are fixed. And most importantly, you need to know that each part of the cardiac tube has its derivatives, and we talked about them, all of them coming from this tube except the smooth area of the left atrium, which is a contribution from the pulmonary veins. This diagram again it states what has been written, so this and this, they are the same. The smooth-walled part of the left atrium is formed by the incorporation of parts of pulmonary vein into its wall. The small wall of the right atrium is formed by the incorporation of the right sinus venosus, but sinus venosus is still part of this tube, that is for sure. So the only part that is coming not from the cardiac tube, it is the smooth area of the left atrium. Now, the part of the tube lying within the pericardial cavity is made up of the bulbous cordis, and this is something you need to appreciate. I may have here maybe this diagram is excellent here. As you can see, this is the pericardium. Not all the cardiac tube is lying within the pericardium. This is something you need to appreciate. So when we talk here, this is the truncus arteriosus is outside of the pericardium. So the part of the tube lying within the pericardial cavity is made up of bulbous cordis and ventricle only. Because of the bulbous cordis and ventricle grow faster than the other regions, so they are inside the pericardial cavity, and they also grow faster than other parts, the heart bends. And this is something you need to understand. If you are within a very limited area and you add up in growth, you would certainly be forced to accommodate yourself in this tight area, and the tube, which has been straight, as this part, the bulbous cordis and ventricle, they grow faster, but because this part of the tube is fixed, and this part also is fixed, and this part on top of everything within the pericardium, so this part would begin to loop and bending. So you need also to appreciate the factors that make the straight cardiac tube to loop. Those are first of all, not all the cardiac tube within the pericardium here, only the bulbous cordis and the ventricle, and also you need to appreciate that the arterial end of this tube is fixed. Until now also the venous end is fixed. The third factor is the fact that the bulbous cordis and the ventricle, they grow faster and within a limited area, and all these factors would certainly force the tube to loop. The heart bends on itself, usually bends to the right, and I would explain this in details as we proceed. Thus, the proximal bulbous cordis lying, which would become the right ventricle, lying anterior and to the right of the primitive ventricle. So you may think we call this as a U-shaped, the bulboventricular loop. The first loop of the cardiac tube is to become like the letter U, but you have to understand what's going on here. Now, the bulbous cordis was above the ventricles. Now, due to the faster growth of the bulbous cordis and the ventricle, and to the all factors that we mentioned, the tube would grow to the right side, would loop to the right side, and as a result, the bulbous cordis would become near to the ventricle, and this is a crucial thing to understand the next step. So if you look here, this is the of course the bulbous cordis, and this is the ventricle. They are now lying near each other. They are lying near to each other. So the difference between this and this is obvious. Bulbous cordis cranial, this one is caudal. Now after the first turn or loop, they are becoming next to each other, and we are talking about tube. So the bulbous cordis and the ventricles, they become near to each other, and they are communicating with each other as they are in fact tube. Now as the atrium and sinus venosus are freed, this end here, the sinus venosus, I told you it was attached to septum transversum, and now as the embryo develops, the sinus venosus would be freed from the septum transversum, and as a result they come to lie behind and above the ventricle. Look, this sinus venosus was here. This is the sinus venosus. Now the arterial end is still fixed, however the venous end is freed. Now because the looping was to the right and anterior, the sinus venosus can't loop up. It has been freed inside the pericardial cavity, but it can't go anteriorly because the anteriorly this part is been lying and occupying this area, and therefore sinus venosus has only one option: to migrate up, to go up. And as a result, here you go, this is sinus venosus. Okay, it was somewhere here, now it migrated where upward, and it became behind the and above the ventricles, behind and above the ventricle, and now it looks like S-shaped, of course, structure, and this is the second loop. The first loop is due to many reasons. The bulbous cordis and the ventricle became near each other. Then the sinus venosus and the atria, which has been freed, they become behind the ventricles and of course above, and in turn we call it S-shaped heart. Cardiac tube, development of the, let me just change the color for you. Here the looping is towards the right side, and that's why here the ultimate the bulbous cordis here and the ventricle, they are near to each other, they are near to each other, and of course this part has migrated up, which is sinus venosus and the atria. Now the atria and the sinus venosum are behind the ventricles, and now the transverse sinus is being trapped between these two ends. At this stage, the embryo is now about 3.2 millimeter long and approximately 25 days old. So we are talking about the end of the fourth week of development, and it poses 20 somites. Of course, we recognize somites, and somites, they indicate the stage. We know, I told you that somites, as they have a pattern where they increase, and we can count them, and we know the stage of development. At this stage, the bulbous cordis and the ventricle are separated by a deep ventricular sulcus, this one here. Of course, they become near to each other, but externally there is a bulboventricular sulcus between them. This sulcus gradually becomes shallower, so that the bulbous cordis and the ventricle come to form one chamber. So if we cut through this area here, you would see this is what we call, of course, look at the atria. They are becoming in their position behind, and this is the bulbous cordis and the ventricle. So they become one chamber. And what is interesting here is this. They were one tube. One of them coiled and become next to the other one, but this does not mean that they are internally separated. They are still one tube. This is the truncus arteriosus, and this is the bulbous cordis, and this is the ventricle, and they communicate. Now this is, if you can see these dots or interrupted lines, they forming a circle. This is the primary interventricular foramen. Primary interventricular, because the bulbous cordis would contribute to the ventricular structure, and the primitive ventricle, of course, would contribute. So they becoming next to each other, and they communicate freely. This area between them is called the primary interventricular foramen. Now the atrial chamber, as you can see here, expand so that parts of it come to project forward on either sides of the truncus arteriosus. Some students who attended the practical sessions, I have demonstrated to them the pulmonary and the ascending aorta and their relations. They as close to each other, and I also demonstrated to you the left auricle and the right auricle, how they come in close relation to with the pulmonary trunk. So the atria, they were becoming behind the ventricles, and they are expanding in a fast way, projecting forward, pushing the truncus arteriosus that would become the pulmonary and ascending aorta. More on that, the atrial chamber expands so that parts of it to come to project forwards on either sides of the truncus arteriosus. As a result of these changes, the exterior of the heart assumes its definitive shape. This is the development of the heart, as simple as you can see. Now, abnormalities of the cardiac looping. Dextra cardia. Dextra, it means right, and of course in Latin, in which the heart lies on the right side of the thoracic instead of the left. So if patients, they have the apex of the heart located in the right side, not on the left side, this means that the heart is dextra cardia, in the right side, not on the left side. It is interesting to know the cause. As you can see, normally the bulbous cordis and the ventricle, they grow into this direction, which is to the right side. So they were growing towards side. The belly of this tube is towards the right side. If you within a pericardium here, and you growing to the right side, you would push this side to the left, and therefore the heart here, the apex of the heart is on the left side. This is normally, I grow to the right side, I'm pushing the tube to the left side, so the heart is located on the left side. Now if the opposite to take place, I'm growing towards the left side, and therefore I would push the heart towards the right side. I'm growing towards the left side here. I would push the other parts towards the right, and the heart and its apex we would find it on the right side. This is as simple as you can see. One event during embryogenesis can have a tremendous consequences in later life, as you can see. Now at the end of looping and rotation of the heart tube, the arterial and the venous ends come closer to each other. You've seen the sinus venosus that we will talk about in details, coming posterior to the, of course, truncus arteriosus. So the arterial end was fixed and stayed fixed. Who migrated to it or moved to it? The venous end, and therefore now the arterial end and the venous end are in a close vicinity and relationship. It should be noted that the atrium and the sinus come to lie behind and above the ventricle. This is what we talked about earlier. It's nothing to be added, but this is an astonishing picture. You can see the looping, and you can see the this is truncus arteriosus. This is of course bulbous cordis here, which is part of it, conus arteriosus in this part, and the right ventricle. We would talk about it, bulbous cordis and its derivatives, plus near to it the of course the primitive ventricle, and as you can see here, the left and right atrium are pushing truncus arteriosus forward to eventually have the ultimate shape of the heart that we know. Now we finished about the looping, and I need just to remind you that the embryo now, this is the cardiac tube in the process of looping and development. It has a venous end and a arterial end. To the venous end, regardless of its position, it has three major veins. The common cardinal vein, this one, and it has anterior part, posterior part. Of course, the umbilical vein bringing oxygenated blood, and the vitelline vein from the yolk sac. Three major veins joining the right atrium. One of the most important out of them is the umbilical, of course, vein that brings oxygenated blood to the embryo. So you need to understand that this tube, the cardiac tube, has venous end and it has arterial end. To the venous end, three major veins, the common cardinal vein from the walls of the embryo, then to the yolk sac, the vitelline, and of course the umbilical vein. So the blood is coming from the sinus venosus to the atria, ventricles, valgus cordis, truncus arteriosus, and this would stay as it is until the heart is differentiated into a new 4 chambers heart. At this stage, the embryo is now about 3.2 millimeter long and approximately about this. We talked about this, but I would just highlight the fact that how small the embryo is. All these events are taking place, and we are now in the 4th week of development. I did mention to you maybe that the most dangerous week is the 3rd week and of course the 4th. Why is that? 3rd week coincides with the menstrual cycle. At the end of the menstrual cycle, females, they may not be aware that they are pregnant, and they may carry on using drugs or may be exposed to X-ray and etc. Therefore, the heart and the cardiovascular system may be affected, though if this effect before the 2nd week of development, nothing would happen. After that, of course, it has to be explained to you in details, but still you need to appreciate that the embryo is too small. We talked about the looping as well. We talked about the veins, and again, this is the way blood flows inside the heart of the embryo. Sinus venosus, primitive atrium, primitive ventricle, bulbus cordis, and truncus arteriosus. In the next lecture, I would certainly talk about the septation of the ventricles and the atria, and we would focus on their clinical correlations or application. Thank you for listening.